Hello everyone, today we are discussing acute aortic thrombosis. Acute aortic thrombosis is a life-threatening condition require early diagnosis and treatment. Etiology embolization, AF, myocardial infarction, embolus lodging at the aortic bifurcation saddle embolus. Number 2, thrombosis in top of atherosclerotic plaque, complication during triple A repair and trauma. There are a confusion about which is common in case of acute aortic thrombosis. Some literature say the most common is embolism. In case of AF, MI, embolus usually lodge at the aortic bifurcation that is called the saddle embolus. And other literature say maybe thrombosis in top of atherosclerosis is more common. Complications during triple A repair and trauma. Risk factors in atherosclerosis, heart disease, smoking, diabetes, and hyperlipidemia, thrombophilia and hypercoagulable state, protein CS deficiency, factor V Leiden deficiency, prothrombin deficiency, and thrombin 3 deficiency. But all those conditions cause more venous thrombosis than arterial. Chronic inflammatory disorder may be associated with them and predispose the factor of acute aortic thrombosis like ulcerative colitis. So the risk factors are atherosclerosis risk factors, heart disease, smoking, diabetes, hyperlipidemia, hypercoagulable state, and thrombophilia, which is more common with the venous thrombosis than the arterial thrombosis, chronic inflammatory disease, ulcerative colitis. Patho-physiology according to Virchow triad, hypercoagulable state, hemodynamic changes, and endothelial changes. And this is pictures of we have laminar flow and shear stress and disturbed flow, and we have here thrombosis plaque and rupture of thrombosis plaque and related adhesion, aggregation, fibrin mesh, and so on of cascade to form thrombus. Hemodynamic changes there are classified during period of acute ischemia to lower limb, kidney, bowel, and effect on the cardiac function, and after restoration of the circulation to vital organ. That's called reperfusion syndrome. So we have two impact and two burden. Either it is immediately during hypoperfusion to lower limb, kidney, bowel, and the effect in the lung and the cardiovascular system, and later on after restoration or revascularization is called reperfusion, ischemic reperfusion injury syndrome, or myonephropathic metabolic syndrome. These classifications for acute aortic thrombosis, either infrarenal, all of them are anatomical classification, and this is at the level of the bifurcation, and this is up to the level of the renal, and this is above the superior mesenteric artery. The effect of acute aortic thrombosis, the direct effect on the different organ, are the following. Cardiovascular system, we have increased blood pressure and increased preload. Shift of the blood from splanchnic vessel to IVC, increase preload. It occurs due to recoil of the splanchnic vasculature once the transmural pressure decreases below the natural recoil of the venous system. Increase the afterload and the end-systolic velocity in case of suprarenal occlusion. Sudden increase in blood pressure, acute compression of the subendocardial vessel ischemia. The ability of subendocardial tissue to adapt started to be compromised, lead to decrease in heart contractility. Perfusion of organs supplied by aorta depend on the level of the occlusion and the collateral pathway. Fluid shift from the intravascular fluid to interstitial space with the release of vasoactive drug decrease cardiac output. So the effect of the acute aortic thrombosis in the cardiovascular system increase the blood pressure and preload, increase preload due to shift of the blood from the splanchnic vessel when the transmural pressure lower than the natural recoil of the venous system, increase afterload and end-systolic velocity, especially when the occlusion present suprarenal, so the heart will eject against occlusion, Sudden increase in blood pressure may cause compression of the subendocardial vessel and cause myocardial ischemia up to infarction, especially if the subendocardial tissue started to adapt it and later on its compromisation will be decreased or prohibited, so it will cause MI. Perfusion of the organ supplied by the aorta will be affected depending on the level of the occlusion and the collaterals, and the flow shifted from the intravascular space to the interstitial space with the release of the mediators and vasoactive drugs which cause a decrease in cardiac output. The effect on the respiratory system increase pulmonary vasculature resistance due to increased blood volume circulated through the pulmonary vasculature, accumulation of the lymphocyte and the complement C3A, C5A, thromboxane A2, which mediate inflammation, non-cardiogenic pulmonary edema. So the main effect of the acute aortic occlusion or thrombosis what's called non-cardiogenic pulmonary edema, and it is mainly mediated by increased pulmonary vasculature resistance due to increased blood volume circulated through the pulmonary vasculature and lymphocytes and complement and substance which mediate inflammation. Renal system. Acute tuberous necrosis (ATN) induced by ischemic reperfusion more in the suprarenal occlusion. The degree of decrease in renal perfusion doesn't correlate with the value of the cardiac output or mean arterial blood pressure, but is mainly mediated by inflammation. The effect of the neutrophil activation and mediators raised seem to contribute significantly to the occurrence of the renal dysfunction, and renal failure requiring at least a transient, if not necessary, permanent dialysis is frequently in the suprarenal as well as the infrarenal occlusion with incidence of 3 to 2% respectively. So the effect in the renal system is ATN and ischemia, and he correlated more with inflammatory mediators, which is correlated to the renal dysfunction more than the hypoperfusion, and the renal failure is a risk, especially increased with suprarenal than the infrarenal occlusion. Spinal cord. The degree of injury inflicted on the spinal cord correlate with the duration of limited blood flow. Hemodynamic hypoperfusion due to thrombosis and occlusion of the feeding arteries. It may be related to embolization. It may be related to distal aortic hypotension distal to occlusion and interruption of the intercostal and lumbar arteries. Proximal aortic hypertension occur after aortic occlusion resulted in increased CSF pressure, decreased spinal cord fluid blood flow. Neural tissue is sensitive to ischemic lead to ATP depletion and disturbed calcium homeostasis. So the spinal cord, the degree of affection depend on the duration of the limited blood flow and the collaterals. And we have different etiology and theory about spinal cord ischemia. It may be related to hemodynamic hypoperfusion through the collaterals and through the arteries due to thrombosis and occlusion. It may be related to embolization. It may be related to distal aortic hypotension distal to the occlusion with interruption of intercostal lumbar and arteries from the internal iliac artery. It may be related to proximal aortic hypertension, especially if the occlusion is the suprarenal, and it decreases the spinal cord blood flow and increase the pressure. And finally, neural tissue is sensitive to ischemia leading to ATP depletion and disturbed calcium homeostasis. This is the picture of the blood flow to the spinal cord. We have here an aorta, segment artery, anterior ramus, posterior ramus, muscle branch, spinal artery, posterior radicular artery, and we have posterolateral spinal arteries and the anterior spinal artery. This is a collection of what's the blood supply of the spinal cord. We have here subclavian artery and give vertebral artery. Vertebra give anterior and posterior spinal artery. We have also intercostal and lumbar arteries. We have artery of Adam's vexin and some collaterals and branches from the internal iliac artery. So all of these are the blood supply of the spinal cord. So the first from the left subclavian vertebral artery, anterior spinal artery, intercostal lumbar artery of Adelvex, and the internal iliac artery. Effect on the intestine and GIT in the particularly supramesenteric supraceliac aortic occlusion can lead to significant reduction in the blood flow to the gut. The severity can range from ulceration, superficial necrosis, up to transmural gangrene of the colon and rectum. Occlusion disease of the femoral arteries or the hypogastric artery are risk factors for developing colorectal ischemia. Metabolic acidosis, increased lactic acid distal to the aortic occlusion, greatly dilate vasculature distal to the occlusion, and it contributes to profound hypotension. Renin-angiotensin-aldosterone system stimulate with the suprarenal occlusion, cause hypertension and hypernatremia. Stimulation of the sympathetic system by increasing catecholamine as a response of the adrenal medulla, which stand the blood pressure. Hyperphosphatemia is noticed in ischemic phase with marked reduction after reperfusion. Prostaglandin release with vasodilatation effect in response of the hypertension, and vice versa with thromboxane E2, which is released with the vasoconstrictor effect to correct the hypotension. All these are metabolic effects during the occlusion and ischemia. Metabolic acidosis and accumulation of the metabolite, renin-angiotensin-aldosterone system stimulation cause hypertension and hypernatremia. Stimulation of the sympathetic nervous system by increasing catecholamine, which cause hypertension, hyperphosphatemia, increase in the ischemic phase and decrease markedly in the reperfusion. Prostaglandin release in case of hypertension with the vasodilatation effect, and thromboxane E2 release with vasoconstriction effect to correct the hypotension. Inflammatory response, development of the inflammatory response during ischemia reperfusion injury. Increase neutrophil complement C3 and C5a, and decrease lymphocytes due to entrapment inside the cells. Reactive oxygen species are increased in the ischemic phase and decreased after reperfusion, then increase again in biphasic pattern. And lastly, reperfusion. It's after revascularization, but it needs another lecture, being reperfusion has discussed and the extensive discussion in the patho-physiology and the symptoms and the complication. The incidence of the acute aortic thrombosis is uncommon and is a very rare disease, but potentially devastating and catastrophic event that require promote diagnosis and emergent intervention. Previous reports indicate mortality rate ranging from 25% to 75% despite advances in vascular surgery and critical care over the past 2 decades. Clinical picture cardiovascular, we have hypertension, arrhythmia, and MI, myocardial infarction. Respiratory, non-cardiogenic pulmonary edema. Low limb ischemia, acute ischemia, critical limb ischemia, and thromboembolism. CNS, TIA, spinal cord ischemia, and hemiplegia. Renal hypertension, ATN, renal failure, and metabolic acidosis. Intestinal mesenteric ischemia, abdominal pain, melena, nausea, and vomiting. So the clinical pictures are cardiovascular effect, respiratory effect, lower limb effect, CNS and neurological effect, renal effect, and intestinal effect. This is the how to manage and this is the management of the acute aortic thrombosis based on data from Crawford et al. And Sink et al. Before the management, we have to investigate laboratory ABG to assess the metabolic acidosis and the electrolyte imbalance, lactic acid, renal function, and hepatic function (CBC), radiological CT angiography, MRA, and ultrasound to assess and diagnose the aortic thrombosis and occlusion, risk factor detection by ECG and echo. Okay, how to manage them? In the first, we have to make very rapidly the CT angiography. If the patient is non-operable or has a malignancy, we have to make palliative treatment after counseling the patient and or the relatives. And then we don't have the facility of revascularization. We are present in the clinic or hospitals without a facility of vascular surgery, so you have to refer. But if you are present in the hospital with a facility of vascular surgery, you have to start immediately heparin to make full heparinization, followed by shifting and induction into the operation room. If we have the thrombosis infrarenal level, so you have in the first trial of transfemoral thrombectomy or embolectomy. If you have succeeded, okay, you have to manage later on reperfusion syndrome. But if you have failed, you have an extra anatomical bypass like axillopathy. But in case of the suprarenal aortic thrombosis, the trial of thrombectomy or embolectomy mostly will not succeed. So you have to do for the first, for the start aortic reconstructions in the form of aortic bifemoral bypass and visceral debranching. So what about the role of the thrombolysis? We have satisfactory results, but only at the level of case reports. We don't have randomized controlled trial. So we can discuss this slide in the following next slides. We have told that the investigation laboratory ABG, lactic, renal function, hepatic function, CBC. So we can see CT angiography of infrarenal aortic thrombosis involving both iliac artery. And we have here also CT angiography, abdominal aortic thrombosis distal to inferior mesenteric artery. This is the axial section of the descending aorta. And we have here inferior to the level of the inferior mesenteric artery thrombosis, inferior to the level of inferior mesenteric artery and the level of the bifurcation. Ultrasound, this is the IPC, which is normal, this is the aorta, and we have here occlusion, distal abdominal aortic thrombosis or occlusion. This is the color flow here in the patent part, but here is occluded. So what's the therapy and management? If the hospital has no facility of immediate surgical intervention, recurs. Severely debilitating patients with end-stage malignancy, palliative treatment with a consultation of the patient and the relatives. Immediate heparinization and immediate transfer to operation room in case fit for revascularization. Trial of the thrombectomy for infrarenal aortic occlusion. Axillofemoral bypass extra anatomical is an alternative option after trial of femoral thrombectomy or embolectomy, or in case of significant clot burden. It provides an efficient revascularization with minimal physiological impact. Axillofemoral bypass is a fit for elderly with advanced cardiac disease. A study conducted through 2 years by Dranger et al. 6 patients aged between 55 to 87 years presented with acute aortic occlusion or thrombosis. One died intraoperative, one underwent transfemoral thrombectomy, and only 4 underwent axillofem bypass. All are survived and no need for amputation. What about the rule of the thrombolysis? We have told it's only at the level of the case report. We have here case report of 79 years old patient with previous history of EVAR 3 years ago, presented with acute aortic thrombosis inside the graft, and it was treated successfully by thrombolysis. If the CT angiography shows suprarenal aortic thrombosis and occlusion, we don't have a good chance to make in the first transfemoral thrombectomy. So we have gained access directly to the aorta and make aortic reconstruction in the form of aortobifemoral with branches grafted to visceral arteries should be considered. So the summary, acute aortic thrombosis is a rare life-threatening event that leads to sudden aortic occlusion. In hospital mortality and morbidity has not decreased over the last 2 decades and mid-term survival remain limited. Reperfusion injury is a severely pathology that can cause death of patient after operation. Surgical reperfusion via transfemoral thrombectomy is usually the first approach. Extra anatomical bypass is an alternative option for revascularization. And this is the reference. Thank you very much for your attendance.